right, this is part 2 of intro ECG interpretation. So we're going to go over the PR segment. So graduate from the P wave to the PR segment. Just a reminder, the PR interval doesn't just consist of the AV node. It involves also the bundle of His and the bundle of branches up until the impulse hits the myocardium. That's when the QRS complex starts. All right, so when you're evaluating the PR segment, you want to kind of see if it's elevated, if it looks not elevated or depressed. And usually the way you determine the isoelectric, kind of the baseline of the ECG is to go from TP segment to TP segment. So here you see the PR segment is below the TP segment, so that is depressed. And here it's elevated. All right, so start with our first EKG. What do you guys think? Diffuse PR depressions. Anything else? And what's the rhythm? Is it sinus rhythm? Yeah, it looks pretty sinus. So I heard pericarditis. What else could it be? I haven't given you any clinical scenarios, so it could be anything. It's like in real life when you just handed an EKG. What could be normal variant? Yeah, it could be normal. Pericarditis, or it could be an atrial infarction, which is very rare. Atrial infarctions, I don't know how clinically significant, but it's very uncommon because actually the atria is perfused by the blood that's in the atria. So if you weren't perfusing your atrium, you'd probably be dead because you had no blood in your atrium. So pretty unrealistic, but not very common. You can be normal variant because you can have like this depolarization of the atria, and it can occur a little bit earlier, which can depress the PR segment. You can see this a lot in tachycardia. So for the ECG features of pericarditis, a lot of times you're tachycardic, you have PR depressions and diffuse ST elevations. You kind of have this like concave up, scooped out appearance of the ST segments, and you can have a notch terminal portion of the QRS complex. So here you can kind of see the notch QRS complexes in like actually almost at every ST segment, but mostly in one. You can see it in two, like you see AVL and AVF. But a lot of times you have to kind of interpret the EKG in the while examining the patient, getting a good history. So that's almost as important. I feel like a lot of our patients just have this EKG.
The other thing, one thing that can help you is to differentiate that from early repole, besides clinical. I mean, that would help you the most in getting an old EKG. But one of the things you can do with that ST elevation is look at the size of the ST elevation to the size of the T wave in the precordial leads, especially the lateral precordial leads. And if it's more than 25%, it suggests that it's pericarditis and not early repole. If it's 20% or less, it suggests that it's probably early repole. But again, it's always, like you said, clinically.
All right, next EKG. So what's going on? Nice, short PR. Is this sinus rhythm? Yeah, it looks pretty sinus. It's up in 2-3 AVF. What's going on here?
Hard to say if it's like a Sinus arrhythmia or like the sinus pause.
It could be. I think it's sinus arrhythmia. I think in sinus pause you might have a little bit longer break in between. You guys know what's your differential for this? Normal variant. WPW is on differential. Junctional rhythm. Nice, you guys hit all three. I think in junctional it may be usually you'll have the kind of retrograde P waves, they'll be like inverted and where they would normally be upright. There's something called, have you guys heard of Lawn-Ganong-Levine syndrome?
Yeah, actually, yeah.
Yeah.
Dr. Sullenberg loves to bring this one up.
Yeah. I remember Dr. Hochstein taught me this and I admitted a patient for it a long time ago, and then there's WW. Let's see. I think in this patient, it was actually LGL. Is LGL clinically significant? It's up for debate. Yeah. Same with WW. Yeah. Not every patient with WPW pattern has WPW syndrome. See. But in LGL, you have kind of these fibers called the James fibers that bypass the large, like the upper 2/3 of the AV node. So you kind of have a short PR, but still conducts to the His bundle branch pathway. So the QRS complex looks normal. All right, next EKG. What do you guys think? What's this sinus rhythm? Anything abnormal looking about this EKG? Short PR, delta waves. Someone said strain pattern. What makes you say strain pattern?
The slower. The upward on 4 before we find it.
You know, like the TOA inversions. Yeah. Okay, so it could be, I guess, on differential, maybe an LVH or RVH pattern. What about here? What's going on here? Are these Q waves? Maybe? No? Is this MI? Esteban says no. What do you guys think this is? This is WPW pattern. So what are the criteria of WPW syndrome? So you have a shortened PR with a normal looking P wave, wide QRS complex, but greater than 110 milliseconds. You can have ST wave changes or abnormalities, kind of like what Shane was saying, a strain pattern. And you have to be associated with paroxysmal tachycardias. So in WW, you have like this accessory pathway that bypasses the whole AV node His bundle branch pathway from the atrium to the ventricles. And the reason why you have this delta waves is because you basically have your atrial depolarization, and some of it goes through the AV node, but some of it bypasses that, and you get early depolarization, and that's how you get this delta wave. But the depolarization is pretty inefficient, and that's why it's very slow, and kind of like you get this slow upslope. And eventually the impulse goes to the regular pathway, and that's much more efficient, and they cancel each other out. All right, and that's how you get this pattern here. And 12% of WW have normal PR intervals. So there are different subtypes, type A, B, and C. The most common is type A, where you have pretty much upright R waves in V1 through V6. In type B, you have a down you have predominantly S wave in V1, and then C you're up in V1, but you also have some downward waves in the lateral leads. So here, what type is this? Type A, yeah. So this is mostly where's my mouse? It's all upright from V1 through V6. And here you can see so these aren't actually now they've determined it's WW. These aren't really Q waves, there's just upside down delta waves in the inferior leads, which can mimic ischemia. So having tall R waves in the kind of V1, V2, it's abnormal, could be abnormal. And there's kind of a list of differential diagnoses that are associated with this. You guys know, besides WW. What'd you say? Someone say something? Yeah. So what else could it be? What else could generate tall R waves in the V1, V2 leads? Right bundle branch, yeah. What else? Pulmonary hypertension causing right ventricular hypertrophy or strain. See, what else?
One more important one, really important one, where the R is bigger than the T. It shouldn't be, when the R is bigger than the S in V1 and V2. We've gone over this so often.
Dr. Senna says posterior wall MI. I think that's all. So these are all pretty, I mean, most of these are pretty important. So whenever I see tall R waves in the kind of the V1, V2 leads, I go through this differential on almost every EKG. So WW, right bundle branch block, posterior MI, you don't want to miss that. RVH or RV strain, maybe you could pick up a PE early on, and then it can be normal in young patients. All right, what's going on in here? CCT.
It seems like a sinus rhythm. It has a left axis. It seems like a regular rate, not super fast. It's a right butt block. Sorry, left bundle block. And no, you don't think so.
Can it be left if it's up in V1, V2?
Oh, yeah.
What's your differential? We just went over this. Lead reversal. The security guy was telling me he got a stress test from lead misplacement on this. I thought that was pretty funny. He said he put on some lotion. He said the leads got all mixed up. He asked me what lecture I was giving because I'm a visitor. So. What do you think of the QRS interval? So wide, yeah. Sinus rhythm wide, upright in V1, V2. Give you right bundle branch block. What else about the morphology of the QRS complex? Shit, I can see it on here. Yeah, this is WW. According to the textbook I stole this from. So these V2, you can kind of see that this to me it looks like a delta wave. Let's see, up in V2. Let's see, even V1 as well. This is type C WW, which is pretty rare. See, all right. Oh. What's going on here? Sinus rhythm? Yeah, sinus. How's the PR interval? Are you saying that because the last 4 EKGs had short EKG? Yeah, it might be short. It's hard to tell 'cause the quality. Yeah. What's here? What else is abnormal here? Someone says LVH.
What do you think about the QRS interval?
Why? Yeah. So can it be LVH with a wide QRS? I guess you could maybe, but what about the QRS complexes in V4 through V6? Also WPW, yeah. These are delta waves as well. What type of WPW is this? B, yeah. I think this in the textbook he mentioned that there's a patient who came in 30 times for syncope, got 20 EKGs, and took the 21st time for someone to figure out maybe this is like a paroxysmal tachycardia from WPW. Yeah. Maybe it's just vasovagal. Our favorite diagnosis.
The other thing that when you're looking at that, when you see that YQRS, the other possibility would be LVH with what's called an IVCD. So you don't see a definite left bundle, but it's suggestive of it with LVH, and the QRS is like a little bit slurred. And so instead of calling it a left bundle branch block, they call it IVCD, intraventricular conduction defect. And it's common in people with really bad chronic hypertension.
Why isn't there a left axis? An ABL is so small.
Lead placement now.
The other thing I just wanted that you mentioned something real quick, but you will see people reverse the leads. And what would help you there is that when you look at one, the P should always initially be going up. And then someone where you reverse the leads, one, the P should be will go down. And AVR, the P should always go down initially. If you reverse the leads, the P will go up in AVR. And if it's just due to reverse leads, though, if you then look at your precordial leads, they will still have the usual normal progression pattern, right? If they have dextrocardia and they have that abnormality from that, in the precordial leads, they'll have an abnormal progression pattern, because as you go from V2 to V6, you will lose your R waves because the heart's the other way. So you can tell if they reverse the leads, which happens, and the rare of one of whether it's dextrocardia.
All right, next EKG.
First degree.
First degree. What makes you say first degree? Yeah, the PR interval is very long. Is this sinus rhythm? Looks like it. Anything else abnormal about this EKG? Yeah, actually, I'm surprised. So yeah, going back to last lecture, P waves are pretty tall in the kind of the inferior leads or distant two. So what's that suggestive of? P pulmonale, which is suggestive of pulmonary or right atrial enlargement. But yeah, this is first degree AV block. Let's see. So let's talk about prolonged PR intervals, kind of how to approach them. Let's see. So when you see a long PR, you kind of ask yourself, is this sinus rhythm? You have to make sure you kind of assess all the P waves in every lead. And are the PR intervals, are they the same all the time or are they varying? Varying. And if they're not, then you kind of have to go through the same algorithm. Are the P's all the same? You know, is there some type of pattern? Do they progressively lengthen? Are they fixed? And do you have group beats where you have like a bunch of QRS complexes together, then you have a pause, and then another group of QRS complexes? And do the P's and Q's, sorry, QRSs communicate? Let's see. All right. So what's going on here? Sorry, see, actually. Sinus rhythm. Dr. Sinner says occasionally. You don't get this long to assign your EKGs. Let's see. Someone says AV block. What type? What degree? Type 1, second degree. What makes you guys say that? Yeah, so you see group beats here, right? So kind of look at the PR intervals. It's slowly, actually not even slowly, it's pretty obvious. So you have the PR interval here and the P wave here and the P wave on the third beat. Actually, I think it's buried in T wave, but it's not even dropped here. So maybe there's another P wave inside the T wave here, and then it drops. So this is secondary. What about these? What about these QRS complexes here? Is this WPW as well? No, I don't know. I don't think so. But yeah, it's like bifascicular. Also think about this guy has really bad chest pain. And they're having an AV block. Consider MI as well. Yeah.
One of the things you would worry about here, especially if the patient came in with near syncope or syncope, is you have here a very left axis, or at least it's down in there. And then you have what looks like a right bundle branch. And then you're having something messing with the P wave, either first degree or in this, or just a Mobitz type 1. You always have to worry, are they going to go into trifascicular block on you? I would worry about this kind of patient with all those different things here, if they came in with syncope or pre-syncope.
Yeah, definitely. All right, next EKG. This is one. Put place on ops. What's going on here? How's the PR interval?
I can't tell. This is not yours.
Yeah, what's the differential here?
Yeah, so it's the third degree.
So Dr. says third degree. So you do see the PR intervals, they're different from the three QRS complexes here. Uh, so probably third, I mean, management wise, does it really matter? Third degree, second degree, this you can probably place that if they're unstable, or I mean, what's the rate here? It's like in the 20s, so you're gonna place a TVP or at least transcutaneously paste them. Yeah, but this is third degree heart block. Let's see. All right.
Why don't we also
But it's a
bother-
pretty common rate for the ventricles to go out when they're switching.
Yeah, so it's probably like a ventricular escape rhythm, right?
Yeah. You know, one other thing that would bother me being my differential, those T's really bother me too. And I just wonder, in the right setting, could this be hyperkalemia causing this heart block?
I would give this patient calcium before, like, if they're like that, and then I think I would just do it.
Yeah, and nothing to lose.
Yeah, there's no harm in it.
Yeah.
Yeah,
Unless
I mean, I would worry me, I wouldn't sit on that.
That's right, hypercalcemic, yeah. I would too. I agree. See. Right. What's going on here? How's the PR interval? Wrong.
Two to one, the type rule.
Esteban says 2-1.
The first degree, I do thought. Oh, it's two.
So it could be second degree. I think actually this is third degree.
I think it's like. CR looks the same.
PR does, is it? I think if you actually, this one's a little shorter.
Well, there's a.
It could be,
P wave and
yeah.
a T wave, so that usually tells you it's third degree. Let me see that.
Yes.
CR is the same throughout.
So I don't know if this, I guess it could be 2-1, but is this is actually look dropped? I don't know.
I would say it's second degree, and you can't say it's type 1 or type 2.
Yeah.
Because there's no second complex to say it's getting longer.
So this would be great for a patient to determine. You could place the patient on telly and actually look on telly to see if you can maybe have more than, sometimes they'll have some group beats and you could be able to determine if it's like first, second degree.
Then you'll know the difference. But
Yeah,
I would measure out. the PR
1,
rate
2,
to see
3,
if
4,
everyone-
5, 6.
If it is, then I would call it second degree, and you can't tell type 1 or type 2.
This patient's going on they're in the 30s, so you kind
Yeah.
of still assume the worst.
No disagree.
No discharge.
But especially I'd worry about that being more dangerous. I would aim on the side of calling it Mobus type 2, but that's the more dangerous one rather than Mobus type 1, and watch that as I would a
And
Mobus type.
you also have a right bundle. Yeah, you also have a right bundle in the left anterior fascicular block, so
Yeah.
probably unstable.
Yeah. You face it in that
yeah,
line.
yeah.
Eric, could you point out the trifascicular there?
So go through your differential, but this is probably right bundle branch block here. And then you're kind of down in your inferior leads. Yeah, left axis. So maybe this is a left anterior fascicular block, which we'll go on over in later lectures. So this bifascicular, so with a second degree block, you have a trifascicular block.
Right bundle with a left axis. And the only thing that could do that is a left anterior.
Without LVA.
And then, yeah, and then you see the PR is long. Right bundle, left anterior, first degree, trifascicular.
And you can get new right bundle left anterior fascicular blocks in an MI as well. So if the patient has severe chest pain, you should start getting diaphoretic. All right. Just some terminology. Do you guys know the difference between AV block and AV dissociation? Doesn't really matter. It's something cardiology might just try to ask you, and so they can distract you while they place a TVP. But third degree AV block, you have more P's than Q's, and AV dissociation, they're about equal. But it doesn't really matter for us. All right. We're going to go over some QRS complex pathologies in the next 10 minutes. There. So when you evaluate the QRS complex, you look at the height, the width, morphology, and the presence of QAs. And we'll go over axis and transition zone on a later lecture. Let's see. So what's going on in here? That's a good point. Is it sinus rhythm? Looks like it, yeah. What's abnormal about this EKG? It's low voltage, yeah. What defines low voltage? Just looks low, right? Yeah, so they're actually numerical definitions of low amplitude QRS. Less than 5 millimeters in the limb leads and less than 10 in the precordial leads. What's your differential? Shane says infiltrated diseases like sarcoidosis, body habitus, COPD, pericardial effusion. I thought that would be the first one. Machine era. All right. So the way I divide it is that anything that increases distance from the leads to the heart can decrease the voltage. Infiltrated diseases and loss of viable myocardium, like in an MI or cardiomyopathy, and just make sure the calibration is not set to half standard. Okay. So you guys pretty much hit a lot of these. So you can actually get it, sometimes forget, you can get an emphysema and pneumothorax. Basically, especially in the lateral leads, your lungs inflate up and the leads are kind of on the lateral side of your lungs. So that may cause low voltage. Jane says sinus rhythm. Nice. What's abnormal or eye popping? Tachycardic, yeah. I guess that's concerning. Let's see. Electrical alternans. Maybe, but it's pretty high voltage. Thin person, yeah. I think you guys see this EKG like 5 times a shift. Yeah, this is LVH. We've gone over this a few times, so I'm not going to go too much, but basically you have very high amplitude. There are a lot of different criteria that you guys can go over at home. All right, and none of them are that sensitive for LVH, but they can be specific. See. What is this? Sinus with PVC. Change says biphasic TOAs were V1 through V4. Someone says right heart strain. What makes you say right heart strain? And there's a tall R wave in V2, right? Yeah, it could be on the differential. What else is on your differential? Displacement leads. What if this patient had really bad chest pain? Could be Wellens. PE. So for this patient had this is right ventricular hypertrophy. So this is kind of a strain pattern in that they're kind of D-wave inversions in the kind of anterior leads. Sometimes you'll see right axis. So make sure you go through your differential. Running low on time. Let me see. This is a good example of RVH with strain pattern. You know, you kind of have these ST abnormalities and T-wave inversions in the anterior leads and also in the inferior leads. You see the S1 Q3 T3 pattern here as well. All right, let's see. So I just want to get to this EKG.
The up and down.
Yeah. What's the rhythm here? Junctional. Is it? Is it this? Yeah, or is this the wide or narrow?
Accelerated junction.
But if it's wide, where is it coming from? If it's that wide, where do you think the?
The
rhythm
junctional is a little bit.
originates?
It's usually almost a normal QRS with
Ventricular.
ventricular rhythm.
But why? Why is it ventricular?
There's no peak wave. QRS is wide.
What's the basis? But why? Why is it going right to the QRS?
You guys see P waves here? No. So this is a ventricular escape rhythm. Anything else abnormal about this EKG?
QRS is like super wide.
ST elevation and 3 in AVF.
P waves are like V4 and 5 and 3 sharp and like the QRS is super wide. So the discord of I consider hypergay situation.
Yeah, this is hyperkalemia. This is idioventricular rhythm. You kind of see some peak T waves here, but peak T waves are only seen in 22% of cases of hyperkalemia. So, you know, idioventricular rhythm, new idioventricular rhythm. You know, hyperkalemia should be on your differential. This hyperkalemia EKG should be seared into your memory, especially at our hospitals. All right, so this hopefully this, you know, if the attending saw this EKG would send this patient to CCT and then they would get calcium, whether in the hallway or on a monitor or not.
But the triage.
Yeah. Fast track, yeah. Oh yeah, what's besides hyperkalemia, what's on your differential for a Y and QRS? It's a pretty big differential. Bundle branch blocks. VTAC, yeah. Scary. So drug tox,
Which ones?
TCA, what else? Anything that affects your sodium channel, Brugada, maybe. Actually, this is a long list. So hyperkalemia, VTAC, idioventricular rhythms, which we went over, drug effects, WPW, SVT with bundle branch blocks, PVCs and PACs that have bundle branch blocks in them. See? And you can kind of simplify into different morphologies. If it's not WPW, it can be either right bundle or left bundle. If it doesn't meet right bundle or left bundle, it's idioventricular. Right. And I think that's all the time we have. But I guess we go over pathological QAs. You guys remember what makes a QA pathologic? One third. Just one third.
Greater than 1/3 of the QRS.
Good, yeah. What else? There's also a width criteria, or just with that would be suggestive of a pathologic Q. It's a little bit less than one small box. So 0.03 seconds. And then you can have this something called a QS wave in V1, which is normal, where you don't have an R wave. So the Q and S wave are merged together. But if you see one in V2, that's abnormal. Right. So there's just examples of benign versus pathological QAs, and to the naked eye, I think if you were going to go through this really quickly, you wouldn't be difficult to notice, right? Because the QAs on the left look bigger than the right, but these aren't pathological, at least by the criteria we went over. Right. Yeah, they're not wide and they're not 1/3, right? Yeah. Here they're just about a little bit less than a box wide. And this is an example of an abnormal QS in V2. I think that's all time we have. Let's see, maybe we'll go over, actually, let's go over one more. Okay. What's going on here? Actually, for everyone. He said Osborne. What's Osborne wave suggestive of? Hypothermia. What else? Something you can see in these other pathologies, but I think a lot of, at least for border view, it's in hypothermia. I think it's a kind of an important EKG to recognize, especially sometimes where we can't get rectal temps in a reasonable amount of time. I had a patient once in CCT pre-COVID era, things were a little slower, coming for respiratory distress, and I couldn't figure out what was going on. They were fluid overloaded, but their EF was normal, and they were consult to MICU. MICU said this is cardiogenic. Cardiology says they have a history of cancer, get a CTA. I was like, oh man, they're not helpful at all. And then and it was almost shift change. And then I was like, finally got an EKG. You can see some small Osborne waves here. And the patient didn't have a temperature because CCT, so they didn't even have an oral temp. We got a rectal temp and they're 86 degrees and got the patient dispoed. Yeah, and they're shaking too. Yeah. So bradycardia, you have the shivering artifact. And these very subtle Osborne waves in the lateral leads. And that's it.
Very good. Pretty good.